Hello, here we are again to our small animal emergency and critical care mini series of lectures from the TH Hospital at the University of Zurich. The topic that we're going to discuss today, as a follow-up of what we had discussed in previous two lectures, still related to fluid therapy in critical care, and the main complement to what we have already discussed is maintenance fluid therapy. We have discussed resuscitation, we have discussed replacement therapy, now we're discussing maintenance therapy. Maintenance therapy in terms of fluid administration in small animal patients is still an area that is largely ignored for the matter of choices that are made for fluid administration, volumes that are administered to those patients, neglect for circumstances where intravenous fluid therapy is certainly no longer needed but still administered to these patients. And so I just want to highlight some aspect that can make easier to recognize the needs and the goals of maintenance therapy. Maintenance therapy is what every one of us and every dog or cat in the world that is healthy and alive does on a daily basis, is to maintain the physiological needs of water that is mandatorily lost by renal excretion, fecal elimination, and insensible losses. For species that also have the ability to control body temperature by sweating, and where sweating becomes a prominent fluid loss, those losses require a replacement that is higher than when sweating is occurring, then it's higher than when sweating is not occurring. That sounds pretty obvious. For the matter of patients that we deal with, horses are the biggest example. And but for what concerns cats and dogs, sweating is not at all a source of losses, whereas perspiration through breathing is certainly a consideration for how much fluid the animal is losing. Otherwise, for every patient, independently whether they can sweat or independently from the activity level that they are pursuing, the urinary losses represent the biggest amount that requires replacement, and such loss for mammalians is mandatory to a fixed extent as a minimum. The goal, as we said, for maintenance fluid therapy, especially for intravenous fluid therapy, is to guarantee fluid distribution both into the intra and extracellular compartment, because we want this water to maintain the balance of intracellular and extracellular volumes. As a reminder, when we approach replacement fluid therapy, the goal is primarily to correct isotonic dehydration, so the extracellular compartment is the primary goal, and that's why isotonic fluid solution are the one that represents the normal choices. And to complement that, balanced isotonic solution certainly superior to unbalanced or high chloride solution. But that is just a short parenthesis. Going back to maintenance therapy, as I said, the primary goal physiologically is to allow fluid distribution to intra and extracellular compartments to replace the mandatory losses that each mammalian animal has. The minimum water requirements of a dog is equal to 1 ml of water per each kilocalorie of metabolic energy that is used by the animal. The metabolic energy used by the animal obviously varies based on the activity level, and that has to be accounted for. Obviously, a patient that sits in a cage, sick and compromised and not moving, he will have only resting energy requirements, whereas a dog that is active and is running around then will have a higher energy requirements. That higher energy requirements, it will be associated with a higher needs of water requirements by the organism. For what concerns a patient that instead is maintained in a hospital in a critical care unit, is fed, we are going to have resting fed energy requirements. And for what concern the amount of water that that dog will need, once you have established or calculated the energy requirement of the animal, you will have in equivalent amount the mLs of water that the animal will need per day. For an example, a 10 kilo dog will have roughly 400 kilocalories of energy at resting fed levels. So sitting in ICU in a cage, being fed, or with artificial feeding, enteral feeding through tubes of various form, or eating on his own, will have about 400 kilocalories of resting energy requirements that will equal or correlated to 1 ml of water as needs for maintenance needs that he will have on a daily basis. For what concern cats, cats are animals that have adapted phylogenetically to resist at drier environments, desert primarily, compared to dogs. And such species is capable of having physiologic water requirements lower than dogs. 0.7 mLs per kilocalorie of energy consumed is what is indicated for a cat that is resting and eating or being fed. The needs at resting level without being fed are slightly lower for both in cats and dogs, just because digestion requires a certain amount of energy that needs to be accounted for in the total needs that the animal has. So just as a summary, a dog will have as maintenance fluid therapy a need of 1 ml per kilocalorie consumed, a cat 0.7 mLs of water per kilocalorie consumed. The formula they put at the bottom of the slide just identifies the standard formula used to estimate the energy requirements in dogs. For cats, we don't have yet such formula, and basically speaking with many friends nutritionists, for an adult cat they estimate 200 to 250 calories a day as the average resting fed energy requirements. And I'm sure that there are many objections, so I don't want to even get into it, but the formula down here is a very easy way to kind of as an estimate, at least in a dog, of how much kilocalorie requirements a dog patient has. In this publication we have worked in conjunction with my mentor and idol in critical care medicine, Dr. Bernie Hansen, and we kind of reviewed the choices of fluids for maintenance therapy, and we wanted to highlight some considerations on the choice of isotonic versus hypotonic fluid solution, because there's still a very sadly wrong interpretation on using hypotonic fluid, on contraindicating using hypotonic solution for maintenance fluids. The easiest thing to think about how do we do maintenance fluid therapy is when we are healthy and happy, we drink, and by drinking we replace and we maintain our needs of water. That water that we drink rarely is isotonic, often is hypotonic or barely or has barely any electrolyte content, And our GI tract allows a preferential absorption of water that then will allow us to maintain our needs at balance. The intravenous administration of fluids has sadly, the intravenous administration of hypotonic fluid has sadly been associated to some alteration, especially in the electrolyte concentrations, that was then interpreted as a pitfall of hypotonic fluid administration. Hypotonic solutions such as half-strength saline, for example, represent a solution that physiologically, once administered intravenously, would allow a certain redistribution of the free water present into such concentration at the intracellular level because of a gradient in osmolarity compared to the intracellular compartment. So that redistribution between intracellular and extracellular that always rely on a certain entropy, so there's never a steady state, the movement is constant across the cellular membrane, is the goal of maintenance fluid therapy. That's why we drink tap water or whatever water we get in a bottle, and we don't drink isotonic solution for maintenance needs. The hypotonic solution, however, have been associated in some studies to the development of hyponatremia. What was not analyzed properly was the volume of hypotonic fluids that these patients were given. So the issue is not by giving an hypotonic solution you make patients hyponatremic, because in an hypotonic solution, and as I will show you in a second, there's more than sufficient amount of sodium to supply the needs of the animal. As what I admitted up to this point is that the maintenance fluid therapy is aimed to restore the water needs that are lost mandatorily by the organism, but also to restore those electrolyte losses that are mandatory. Through the urinary excretion, mandatory losses of sodium or potassium occur independently from intake. So the replacement with either the diet or whatever fluid are administered of those electrolytes that are being lost by renal excretion, that is, as I said, mandatory, is the other component of maintenance fluid therapy. In an isotonic solution, a classic example, half-strength saline, there are 77 milliequivalents of sodium and 77 milliequivalents of chloride. Concerning the losses of sodium that a patient normally has, or a million normally has, for example, a dog, the losses are equal to about 1 milliequivalent per kilogram per day. So let's bring the example of the dog that we mentioned, the 10 kilogram dog that we mentioned initially. It will have 400 kilocalories of resting fed energy requirements. That will equal to 400 mLs of maintenance fluids that he needs. At the meantime, by losing those 400 mLs of fluid by mandatory losses, he will lose about 1 milliequivalent per kilogram of sodium, which will equal to about 10 milliequivalents of sodium per day. Milliequivalent, obviously, or millimole are identical for what concerns sodium because the valence is 1. Those 10 milliequivalents of sodium are the ones that have to be replaced with maintenance fluid therapy. So if you consider, as I said, half-strength saline, we will have 77 milliequivalent in a liter. So if we are giving 400 mLs of such solution intravenously to replace the water losses, automatically we will be giving roughly 33 milliequivalents of sodium. There is more than plenty to replace the sodium losses of that patient. So the studies that have shown the development of hyponatremia by administering an hypotonic solution sadly have not accounted for the excess fluid that these patients were receiving over their actual needs. Obviously, by giving an overzealous amount of hypotonic solution, you'll be administering a large amount of free water they will end up eventually being accumulated, especially in patients that cannot lose all that free water, patients with renal compromise, or patients that are critically ill, or patients with an increased non-osmotic release of vasopressin, which many critically ill patients do. And those patients will have a preferential retention of free water. And if by intake you are already giving level amounts of these solutions containing free water that is in excess to the needs of the patients, that will develop hyponatremia. But the issue is not with the solution that is chosen, because it's actually an ideal solution for maintenance fluid administration. It's just in the volume that is chosen. Certainly if we are giving twice as much volume compared to the needs that that patient has, yes, those patients will develop hyponatremia, but it's because we are giving too much fluids, not because we are making a wrong choice by using an hypotonic solution. That has been clarified over and over in a number of editorials and a number of more recent studies. And these considerations are more and more important the sicker the patient is. So in our scenario of critical care medicine in small animals, this scenario is fairly common, where patients are kept on intravenous fluids no matter what. And after the sicker they get, the more fluids they receive, which is already a sad aspect of a mistaken interpretation of the therapeutic effect of fluid administration. But for the maintenance standpoint, it's still rare to see a definitive attention to what actually maintenance fluid therapy is and aimed to. And often isotonic solutions are chosen just for convenience, because then we wouldn't have to monitor the amount of fluids that these patients need and electrolyte imbalances they may develop. But once again, the choice of hypotonic solution for maintenance therapy is the most ideal, the most physiologic, and the one that guarantees certainly the replacement of the free water needs, as well as the electrolytes, primarily sodium, to which obviously will be added potassium, which are the one that are lost in the most significant amount on a daily basis through the urine. So those solutions complemented with potassium supplementation at maintenance level will be more than adequate. However, if administered in excess to what the patient needs, yes, certainly can cause free water excess administration, and if that free water is being retained because of inability of renal excretion that these patients may have, then they will develop hyponatremia as a consequence of the excess free water that they have retained. That hyponatremia is not at all an indication that they have a sodium deficit. That hyponatremia is a representation, in a vast majority of cases, of free water excess. And we will have a lecture primarily related to sodium and water balance. But I want to start making the point that in these cases, patients that are on fluids, patients that are on hypotonic fluid solution, if they develop hyponatremia, is always iatrogenic, given represented as an excess of free water administration, and not due to the fact that we are not administering sufficient sodium. So it's not a sodium defect. A patient with a true sodium defect, by definition, will present with signs of hypovolemia. A classic example in Addisonian crisis, the patient that is critically ill administer hypotonic solution for maintenance that develops hyponatremia. Instead, is a patient that is retaining free water until proven otherwise, and that meant that we are giving such solution in excess to the needs that he have. I hope that this was clear. I know I repeated it to the nausea, but it seems still a hard topic to digest for some reason, although it seems to be pretty simple. Excessive administration of fluids, as we said, is wrong no matter what. If it's a hypotonic, often will induce hyponatremia. If it's isotonic, what will lead to is excess of both water as well as sodium. So what these patients will develop is actually volume overload, which we are going to have a whole lecture just about it, just to show how terrible it is and even how early stages of such condition, which is a iatrogenic induced disease. Volume overload, until proven otherwise, is a iatrogenic induced disease, is especially in hospitalized patients. Then would be definitely a consequence of excessive administration of isotonic fluids. For what concerns some shortcuts to determine how much fluid for maintenance a patient needs, well, there are a few things that we can account for. The insensible losses, which are the one that we don't account as urine or fecal water, which is basically breathing, the only thing that is left in a cat or a dog, accounts for about 15 ml per kg per day. So if we have a patient that is oligonuric, for example, or anuric, and he doesn't have any renal fluid excretion, the amount of water that patient needs is in a ballpark of about 15 ml per kilogram per day. A dog that instead has a fairly normal renal function and normal urine output, then will have maintenance fluid, maintenance water needs around 40 ml per kg per day. The cat instead will be roughly 30 ml per kg per day, which are, as I see, are fairly commonly used volume in many occasions. Lean body weight should be the one that is accounted for and not the weight of an obese patient. The comparison of fluid therapy in terms of amounts has now been done for a number of conditions: patients with acute kidney injury, patient with acute lung injury. This is one of the early publications that compared the use of a liberal strategy as fluid administration versus a conservative strategy just to maintain hemodynamic stability. And what he showed that in this population of patients with acute lung injury, the administration of fluids for maintenance needs at a very conservative level is the one that allowed to a more rapid recovery from acute lung injury and a better outcome. So for specific conditions such as acute kidney injury, acute lung injury, the advantage of using a very conservative strategy on amount of fluids administered just to support the minimum needs of a patient over a choice that is more liberal based on dogmatic prescription of fluids to patients in a hospital has shown strong advantages. Now, I want to add a couple of slides more related to the supplementation of other elements besides the sodium, as I said. So I put some formulas and more related to osmolarity of a solution and some consideration about that, as well as amounts of some electrolytes that are commonly used as maintenance electrolytes for our patients. For what concerns the osmolarity of a solution, the osmolarity of any solution is established by the concentration of electrolytes within it, including lactate as well if it's present in a solution, plus the amount normally of dextrose that is within it, divided by obviously the molecular weight of monohydrate dextrose or glucose, which is, by the way, 198. So if we account, for example, LRS, standard Ringer lactate solution, will have 100 milliequivalents of sodium, 109 milliequivalents of chloride, 4 milliequivalents of potassium, 1 of calcium, and 28 of lactate. It doesn't contain any dextrose, so the total will come as 271 milliosmol per liter, which is pretty close to the osmolarity of plasma. So LRS will be obviously considered a iso-osmolar type of solution. For what concerns, for example, half-strength saline, then we will have 77 milliequivalents per liter of sodium, 77 milliequivalents of chloride, and nothing else. So the total osmolarity of that solution will be 154, which is obviously lower, basically half of plasma. So that is, by definition, an hypo-osmolar solution. Here I have the example of D5W, or 5% dextrose solution, where the osmolarity again is lower than plasma, but also an important consideration of D5W is that once dextrose is metabolized by the system, that solution that is nearly isosmolar become drastically hyposmolar, because once the dextrose is being metabolized, that is pure free water. So 1 liter of D5W is equivalent to 1 liter of free water administered to a patient. For a 50% dextrose or 50% glucose solution, the osmolarity is extremely high, is 2500, which is also at that level histolesive, and that's why it should never ever be administered through a peripheral catheter as a concentrated solution. Through a central line can be administered concentrated, but through a peripheral line should always be diluted to a safer concentration and osmolarity. For electrolyte replacement, I left here, I put on this slide a formula that I think it could be handy to remember to decide how much potassium to add to a fixed amount of fluids for replacement needs. The replacement rate at maintenance, again, is aimed to replace those mandatory losses of potassium that a patient has, which is still somewhere around 1 milliequivalent per kilogram per day. So the 0.05 milliequivalent per kilogram per hour, that's where it comes from, which is the minimum need to replace the renal losses of potassium that any patient has. So how do you calculate how much potassium to add to a liter solution of any solution that doesn't contain potassium, for example? You decide the rate of replacement, 0.05 or higher, depending on the deficits of potassium that such patient has, multiplied by the body weight in kilogram to calculate the total amount of potassium that each hour that patient needs. If it's a 10 kilo patient, if you decide to do 0.05 milliequivalent per kg per hour, would be 0.5 milliequivalent per hour total that this patient needs. The calculation of a maintenance fluid rate in ml per hour is done the same way that we said before. So if it's a 10 kilo dog and it needs 400 mLs of water per day divided by 24 hours, you're going to have your total amount in mLs per hour. That is the fluid rate that that patient needs. And then the formula to calculate how many equivalents of potassium had to be added to a liter of IV fluids to achieve the rate of 0.05 milliequivalent per kg per hour would be the total potassium per hour that, as we said, would have been 0.05 milliequivalent per kg per hour multiplied by 10 kilograms, so 0.5 milliequivalents of potassium per hour, divided by the fluid rate, which we said is 400 mLs a day for a 10 kilo dog, divided by 24 hours, we will have the mLs per hour that patient is, multiplied by the volume in which we want to dilute. If we have a liter bag, we multiply by 1,000 mLs, and that will tell us how many milliequivalents we need to add. So here we have the example that I just mentioned. It's a 10 kilogram dog. The potassium replacement is 0.005 milliequivalent per kg per hour. Multiplied by 10 is 0.5. The maintenance fluid rate is 40 ml per kg per day, 16 mLs an hour. So milliequivalent of potassium to add to a liter of fluid is 0.5 divided by 16 times 1,000, which is a 1 liter bag, 1,000 mLs, is 31 milliequivalents. The concentration of potassium in a vial is commercially available 2 milliequivalent per ml. So that means that 31 milliequivalents would be 15.5 mLs of potassium to be added to a liter bag to then run it at 16 mLs an hour and guarantee a replacement at the rate of 0.05. The same applies for phosphorus supplementation. Normally the phosphorus supplementation is done only when there's a true deficit of phosphorus, and those in some conditions like diabetic ketoacidosis is one of them, and or in severe hypophosphatemia conditions. Those are the scenarios where potassium phosphorus supplementation normally is done. Otherwise, diet and bone metabolism is able to maintain those needs. The formula is the same. The consideration is just about the potassium phosphate, for example, the commercially available, that contains 3 millimoles of potassium of phosphorus and 4.4 milliequivalents per ml of potassium. So that when you have a patient that is in need of both phosphorus and potassium, what normally happens, we do the calculation of how much phosphorus a patient needs, and then by knowing the total amount of potassium that is contained in those solution, we just subtract from the potassium chloride that additionally we want these patients to receive. And that is how you will be calculating phosphorus needs and phosphorus volume to be administered. Same thing for magnesium. Once again, 0.04 milliequivalent per kg per hour is kind of what is considered the maintenance needs for a patient that is hospitalized. Consider an important aspect that although magnesium is still is still an electrolyte that is rarely kept in strong consideration unless it goes down to drastic decrease concentration in plasma, is actually recognized to be the most common deficiency, electrolyte deficiency in critical care patients. Dextrose supplementation seems to be pretty obvious. The formula that I recommend to anybody is to use the concentration times the volume equal the concentration 2 times the volume 2, meaning if you have a solution in the vial that is 50% and you want to make it 2.5% solution, the calculation is pretty easy. So 50% times an X volume that needs to be pulled from the vial to be added to a liter bag to make it 2.5% is 50% times X equal 2.5% times 1,000, which is 2,500 divided by 50 mLs, or 50% dextrose to be added to a liter to make it 2.5% solution. This is pretty stupid. To add anything else to any type of infusion rate, this formula is the easiest that I could think of, because it allows you to determine how much of a drug or a supplement needs to be added to a solution to then guarantee the infusion rate that you are trying to achieve. So let's say you want to know how much ketamine or how much lidocaine or how much methadone or any other drug that you might want to add to a solution, to make guarantee that the rate at which is being administered as a constant rate infusion is accurate, and you want to know how many milligrams you want to add of this drug to the volume that you have available, whether it's a liter bag, half a liter bag, 250 cc bag, or a 60 cc syringe or a 20 cc syringe. With this calculation, it's pretty easy to know how many milligrams of a drug needs to be added. So if you have here, the goal is to calculate how many milligrams of drug to be added to a diluent volume. If you know what rate of that drug you want to use in milligram per kilogram per hour, divided by the fluid rate that that patient would be on in ml per kilogram per hour, and multiply by the diluent volume, again in ml, whether it's a 60, if it's a 60 cc syringe, a 20 if it's a 20 cc syringe, or 1,000 if it's a liter bag of fluids, will allow you to calculate very quickly how many milligrams to add. And this formula allows then, just by changing the rate, the fluid rate, according to the body weight of the patient, to guarantee that the concentration, that the rate of administration of a drug that has been added to that solution will be always constant. So if you want to add 1 milligram, if you want to have a ketamine infusion rate at 1 milligram per kilogram per hour, and you know that that patient will be maintained at 2 ml per kg per hour, 1 divided by 2 is going to be 0.5, multiplied by the diluent volume, let's say 1,000 mLs, would be 500 milligram of ketamine to be added to a liter solution to guarantee that fixed concentration. So if I be running that solution at 2 ml per kg per hour, as I put in the calculation, and the dog weighs 1 kilo, 10 kilos, or 100 kilos, it wouldn't matter. You will still be receiving 1 milligram per kilogram per hour of ketamine. So with this I concluded the presentation about maintenance fluid therapy. I hope that was helpful for some extent. As always, I will keep updating our videos and adding new ones. Here are my babies. Thank you very much and have a wonderful evening. or day, or morning, or night. Bye.